Thank you, madam. Thank you, madam. Good afternoon, all of you. I am Rathai Janahan, Senior Registrar at Kalubowila Hospital. Beyond the lungs, the multisystem presentation of granulomatosis with polyangiitis. First, I would like to start with the case history. A 30-year-old female patient from Oklahoma was referred from the endocrinology clinic in February 2025 for further evaluation of young onset hypertension associated with an elevated ESR and renal impairment. The background history: she has a known history of mild to moderate mitral regurgitations since the age of 7 years and has been on regular cardiology follow-up. 2 years prior, she was diagnosed with hypertension and commenced on losartan and diltiazem. However, she defaulted on treatment for more than a year. She subsequently presented with non-specific headaches and clumsiness of the hands. Evaluation for secondary causes of young onset hypertension was undertaken and endocrine causes were excluded. During the workup, she was found to have impaired renal function and a persistently elevated ESR. Concurrently, she was assessed by the neurology team for the clumsiness of the hands. The MRI of the brain revealed multiple microhemorrhagic foci in both cerebral hemispheres, predominantly involving the peripheral regions with associated cortical and subcortical gliosis. The imaging features are non-specific and differential considerations were included as prior traumatic injury, chronic ischemic changes, or post-COVID. And the nerve conduction study showed there was no evidence of bilateral cervical motor radiculopathy or anterior horn cell lesion. During our clinic visit, there was no constitutional symptoms such as fever, fatigue, malaise, anorexia, or weight loss, and she didn't have arthralgias or myalgias or skin lesions, and no complaint about nasal crusting, rhinorrhea, epistaxis, or sinusitis. And she didn't have ear pain or hearing loss or hoarseness of voice, stridor, dyspnea, or wheezing. And no complaint of pleuritic chest pain, cough, or hemoptysis. And she didn't have hematuria, frothy urine, facial puffiness with angle edema at that moment. And no complaint of eye pain, visual disturbances, diplopia, red eye, or proptosis. She had right upper limb weakness. There was no numbness or paresthesia in the hands or feet, or she didn't have fits. There was no recent exposure to medications or drugs such as hydralazine, propylthiouracil, cocaine with levamisole, methamphetamine, or cannabis. There was no claudication, headache, abdominal pain after meals. There was no photosensitivity, oral ulcer, hair loss, or Raynaud's phenomenon. She was on losartan 25 mg BD and diltiazem 60 mg TDS. Her mother had myasthenia gravis and father had hypertension. She is unemployed and unmarried, and there was no history of substance abuse. On examination, she is afebrile, pale, there's no skin lesions or tight skin, no red eye or proptosis, there's no evidence of nasal or oral ulcers, nasal crusting, nasal discharge, or saddle nose. There's no angle edema, no splinter hemorrhages, no vasculitic rash over finger bulb. Respiratory rate was normal, vesicular breathing, and no added sounds. There was no bruit, no pericardial trap. There was mitral regurgitation murmur. Pulse rate was 84. All peripheral pulses were present with good volume. Blood pressure was 130/80 in both arms while on treatment. There was no cranial nerve palsies, no cerebellar signs, no sensory loss. In right upper limb, there was motor weakness with power of 3 and left power of 4. During the first visit, she came with some investigations. Full blood count, WBC was nearly 6,720, HP 10.3, platelet 142,000, ESR was 49, CRP normal, UFR was normal. Blood picture shows the evidence of relax formation suggestive of infection or inflammation, anemia of chronic disease, and mixed deficiency anemia. At this point, we thought of the possible differential diagnosis of SLE vasculitis, Takayama arthritis involving possible renal artery, and associated vasculitis. And we started treatment with oral prednisolone 1 milligram per kg and bone protections with calcium carbonate and vitamin D. She reviewed in 2 weeks. At that time, she presented with left leg edema and there was ruptured blister. She got treatment from Ayurvedic doctor. She applied pattu and everything. And she came with the immunological report. ANA was negative and the substandard DNA was negative. The CNK was positive and PNK negative. So we did the dermatology referral for skin biopsy. As we have the one of the differential diagnosis associated vasculitis, and here CNK was positive. So they suggested to treat as cellulitis, and at this point biopsy not done. Again, we reviewed in 2 weeks time. There was persistence of leg ulcer, full blood count, WBC nearly 10,000, she was on steroids, platelet 185,000 and HB was 10.3, chest X-ray was normal, ESR it was increasing in trend 98 and CRP normal, serum creatinine, she had the serum creatinine record of 1.43 before our clinic visit, and now it increased to 1.56. UFR showed protein and UPCR was 29.75 milligram per millimole, subnephrotic range protein. Echo with there's murmur, there's no vegetations. As she had hypertension, persistent vasculitic ulcer, subnephrotic range proteinuria, increasing ESR and positive CNK, we diagnosed as granulomatosis with polyangiitis. We referred for nephrology team for renal biopsy. While awaiting for the renal biopsy, we started management with methylprednisolone pulse 500 milligram for 3 days and MMF, and it increased in 2 weeks time because earlier she denied for the renal biopsy. So to preserve the kidneys, we started our treatment. While awaiting for renal biopsy, she had 1 episode of generalized tonic-clonic fits and treated with levetiracetam. At that time, electrolytes, NC brine and LP were normal. EEG showed occasional theta signals with normal background compatible with epileptogenic. So we thought possible due to prior lesions or CNS vasculitis and planned to do cerebral angiogram. Sorry. So we did other investigation to exclude infective causes of vasculitis and useful for the preparation for biologics. Sputum AFB and gene expert, hepatitis B and C screening, retroviral screening and EBV CME antibodies all were negative. So during the next follow-up, there is the increment in the UPCR, serum creatinine there is improvement and ESR also improved. APLS screening negative. Ultrasound scan of abdomen showed early CKD of bilateral kidney showed 8.02 centimeter. CT iotogram and cerebral renal and pulmonary angiogram, there was no luminal narrowing or wall thickening to suggest vasculitis, no aneurysms or AV malformation detected, and there's no renal artery stenosis. But they mention there are small nodules in the superior segment of left lower lobe, which is probably inflammatory nature with probable intrapulmonary lymph nodes. There was no evidence of chronic sinusitis. While awaiting for renal biopsy report, we treated with IV rituximab 1 gram 2 weeks apart. Later, renal biopsy shows the evidence of necrotizing post-immune vasculitis suggestive of ANCA-associated vasculitis. Post-rituximab, there is significant improvement in the UPCR, serum creatinine, and UFR and ESR. The vasculitic ulcer healed. The prednisolone gradually tailed off regime according to the Pexivas trial, and rituximab 500 mg 6-monthly regimen was started. Now I move to talk about granulomatosis with polyangiitis. It's formerly known as vaginous granulomatosis. It's a rare multisystem autoimmune disease of unknown etiology. GBA is one of the ANCA-associated vasculitic disorder which can affect the ears, nose, throat, respiratory tract, skin and kidneys and nervous system. Its hallmark feature include necrotizing granulomatous for inflammation and post-immune vasculitis in small and medium-sized blood vessels. The historical evaluations in 1897, Peter McBride provided the first likely written description of a condition consistent with granulomatosis with polyangiitis. Again in 1931, Klinger described a detailed case of 70-year-old physician with constitutional symptoms, arthritis, proptosis, disruptive upper airway disease, pulmonary lesions and glomerulonephritis. In 1936, Frederick Wegener reported 3 patients with a distinct clinical and histopathologic pattern leading to the eponym Wegener's granulomatosis. In 1954, Goodman and Sharp defined the classical pathological triad of granulomatosis with polyangiitis. Nomenclature change. The ACR and EULAR recommended replacing honorific eponyms with descriptive disease names. This change was supported by the historical concerns regarding Wegener's past narcissist activities. Epidemiology. Prevalence 2.3 to 146 cases per million. Incidence 0.4 to 11.9 cases per million. It's most commonly occur in adults, although this disease have been reported at all ages, as males and females are equally affected. Pathogenesis. In genetic predisposed people, the triggering factors, for example, infections or environmental factors, they stimulate B cells, T cells and neutrophils. The results of stimulation of neutrophils, they express PR3 and MPO and translocate into cytoplasmic membrane. So it causes B cell activate. It produces the B cell activating factor, and it activating and promoting the B cell survival. So these B cells again form the ANCA and stimulate the neutrophils. So then this cycle continues, and accumulation of PR3 and MPO, it accumulates in the vascular endothelium and produce the reactive oxygen species and lytic enzymes which cause endothelial injury. So these neutrophils activate, neutrophils activation will cause neutrophil extracellular trap, and it causes the activation of complement system, and it produces the chemokine C5a, and it activates the neutrophils. Here the neutrophil extracellular trap, it activates the dendritic cells with the T cells, and it also produces the it stimulates the ANCA formations, and the T cells and dendritic cells with the chemokines, it's promote the formation of granuloma. So pathogenesis is important because the new emerging trends are targeting these pathways. Clinical features. The granulomatosis with polyangiitis has a spectrum of clinical presentations that include non-specific symptoms and organ-specific involvement. The initial non-specific constitutional complaints include fever, night sweats, fatigue, lethargy, loss of appetite, weight loss and anorexia, arthralgias, rhinosinusitis, nasal crusting, and cough and dyspnea. In ear and nose manifestation, there was chronic sinusitis, rhinitis, epistaxis, collapse of nasal support resulting in saddle nose deformity, nasal crusting. They can have conductive sensorineural hearing loss, and tracheal or subglottic granulomatosis masses. In pulmonary manifestation, they can have cough, hemoptysis, chest discomfort, dyspnea, stridor, wheezing, and pulmonary infiltrates, nodules, and fibrosis, and pulmonary artery hypertension. They can have diffuse alveolar hemorrhage and tracheal or subglottic stenosis. In renal manifestation, they can present with hypertension, hematuria, rise in serum creatinine, variable proteinuria, and finally kidney failure. Neurologic manifestation in the peripheral nervous system, they can present with mononeuritis multiplex, sensorimotor polyneuropathy, cranial nerve palsies, and sensorineural hearing loss. In central nervous system manifestation, vasculitis of small to medium sized vessels of the brain or spinal cord can happen. Granulomatous masses that involve the orbit, optic nerve, meninges, or brain also can present. As ophthalmic manifestation, they can present with retroorbital tumor, conjunctivitis, episcleritis, scleritis, uveitis, optic nerve vasculitis, or nasolacrimal duct distraction. And they can have cutaneous manifestation as well as palpable purpura, skin lesions, petechiae, vesicles, pustules, hemorrhagic bullae and reticularitis, and digital necrosis, and subungual splinter hemorrhages and genital ulcers. And they can have musculoskeletal manifestations and cardiac manifestation as pericardial rap, myocardial infarctions or sudden death, and gastrointestinal involvement due to splenic circulation involvement, and they can have deep vein thrombosis as well. In some studies, they talk about there's large vessel involvement in granulomatosis with polyangiitis. It's possible polyangiitis overlap syndrome. So there's a retrospective study conducted by Mayo Clinic, and they reported as temporal arteritis was seen in 5 out of 345 GBA patients. So another study in Switzerland, they found to have the evidence of large vessel involvement in 5 out of 58 GBA patients. 3 out of them have temporal arteritis and 2 of them have aortitis. Diagnostic evaluations, lab test, UFR and renal function test. In patients with renal impairment, they can have proteinuria and red cell cast. Full blood count, they are mild normocytic normochromic anemia, and leukocytosis is common with neutrophil predominance. inflammatory markers will be elevated, and rheumatoid factor is positive in low titer in 2/3 of patients. Anti-neutrophil cytoplasmic antibody testing, the negative serology does not exclude the diagnosis. Cytoplasmic anti-neutrophil cytoplasmic antibody directly against PR3 is most specific for GBA. Some patients with GBA express perinuclear staining and cough. This combining immunofluorescence and the ELISA enhances the sensitivity and specificity of the diagnosis of ANCA-associated vasculitis. This picture shows that CNCA immunofluorescence pattern is staining for anti-neutrophil cytoplasmic antibody by indirect immunofluorescence shows heavy cytoplasmic staining, whereas nuclei are non-reactive. Other picture, the PNCA immunofluorescence patterns, perinuclear anti-neutrophil cytoplasmic antibody staining pattern by indirect immunofluorescence shows perinuclear staining, whereas cytoplasm is non-reactive. Chest radiography and CT scanning. The chest imaging should be performed in all patients with respiratory symptoms. The most common radiologic findings are single or multiple nodules or masses. The nodules are typically diffuse and approximately 50% are habitated. They can present with diffuse alveolar opacities, atelectasis and obstructive pneumonia caused by bronchial stenosis also can be seen. So the findings on CT scans include consolidations, patchy or diffuse ground glass opacities, and additional CT findings include stenosis of the larynx or tracheobronchial tree, bronchial wall thickening, and bronchiectasis, pleural thickening or effusion, and lymphadenopathy. So these images here, it shows extensive thickening of maxillary sinus in a patient with granulomatosis with polyangiitis. This is a diffuse patchy meningeal enhancement in contrast enhanced T1 weighted MRI images, and here left ethmoid sinus disease are mentioned. This X-ray shows there is pulmonary nodules. Here this halo sign, and there are also some opacities are there. This picture shows some habitative lesions. This HRCT report showing bilateral habitating nodules. Here diffuse alveolar hemorrhages. Other studies, biopsy. When possible, a tissue diagnosis of an active site should be completed. Renal and lung biopsies are most specific for granulomatosis with polyangiitis. Crysenteric necrotizing granulomatosis is the most common renal finding. The patients with lung involvement, pulmonary testing, spirometry, plethysmography, and DLCO can be performed. And bronchoscopy also helpful in the diffuse alveolar hemorrhage patients and airway diseases. This is classification criteria for granulomatosis with polyangiitis. Here there is a clinical criteria and laboratory imaging and biopsy criteria. With the scoring of 10 items, a present score of more than 5 or equal needed for evaluation. Here you can notice there are minus scoring system for the positive test for perinuclear anti-neutrophil cytoplasmic antibodies and blood eosinophil count more than 1 × 10⁹. The differentiations from other ANCA-associated vasculitis, granulomatosis with polyangiitis, it's typically involve END, lung and kidney involvement. In END, it causes necrotizing, destructive lesions, lungs causing nodules, masses, cavities, infiltrates and diffuse alveolar hemorrhage as we have seen now. And histology also shows granulomatosis inflammation in vasculitis. In eosinophilic granulomatosis with polyangiitis, it's associated with eosinophilia. Asthma is a predominant respiratory symptom, and END symptom, they are allergic symptoms and it's non-destructive. And lungs, infiltrates and nodules can present. Diffuse alveolar hemorrhage is rarely seen there. Kidney involvement also less likely. Heart is often involved and associated with damage and higher mortality. And here ANCA mainly MPO. In microscopic polyangiitis, it's typically lung and kidney involvement. END considered to be a rare manifestations. Lungs, pulmonary fibrosis and diffuse alveolar hemorrhage can happen. Kidney, they can more chronic lesions, and heart involvement is uncommon. ANCA more often present but not exclusively associated with MPO. Here I have mentioned some organ life-threatening and non-organ life-threatening manifestations of ANCA-associated vasculitis, because the management guidelines depends on the organ or life-threatening or non-severe diseases are different. So examples of potentially organ or life-threatening manifestations: granulomatosis, pulmonary hemorrhage, meningeal involvement, central nervous system involvement, retroorbital disease and cardiac involvement, mesenteric involvement and mononeuritis multiplex. So other examples of manifestations that are ultimately organ, that are not ultimately organ or life-threatening: nasal and paranasal disease without bony involvement or erosions or cartilage collapse, or skin involvement without ulcerations, myositis, non-cavitating pulmonary nodules and episcleritis. But these classifications is just for a guide, but it may vary depend on the patient's presentations and the investigations findings. When we had the patients, at that time we had 2022 ELA algorithm management guidelines. Now we have PSR 2025 guideline from last June. Here the presence of life or organ threatening diseases, they have suggested the induction of remission with cyclophosphamide or rituximab. If there is a severe kidney involvement, consider adjuvant plasmapheresis, or if need, you can combine cyclophosphamide with rituximab as well. If non-life threatening, you can go for rituximab or methotrexate or MMF. And for the relapsing of the disease also, now they have recommended we can go for rituximab. So with the rituximab or cyclophosphamide, we can combine with glucocorticoids, and now they recommend we can use the avacopan to use the side effects of the glucocorticoids and taper glucocorticoids according to the Bexiva's trials. In remission, so we can continue rituximab for 24 to 48 months in 6-monthly interval, and we can continue glucocorticoids and taper and target to tail of the prednisolone at the 4 to 5 months of period. It's 5 milligram. If we sustain remission, we consider immunosuppressive drug withdrawal. This is glucocorticoid weaning regime reduced dose glucocorticoid weaning regime in Pexivas trial in the life-threatening conditions and the Loas trial in the non-severe disease. They are targeting the prednisolone dose of 5 milligram, nearly 4 to 5 months of the induction of remission. In some conditions, we prefer rituximab and some cyclophosphamide. Rituximab is preferred in children and adolescents, premenopausal women and men concerned about their fertility, frail old adults, and relapsing disease and PR3 ANCA disease. Cyclophosphamide is preferred when difficult to access the rituximab, and severe glomerulonephritis with serum creatinine more than 4 milligram per deciliter. Combination of 2 intravenous pulses of cyclophosphamide with rituximab can be considered. The maintenance of regime, in some instances we prefer rituximab and some azathioprine. So rituximab is preferred in relapsing disease, PR3 ANCA disease, and frail older adults, and azathioprine allergy. And azathioprine preferred in low baseline IgG less than 300 milligram per deciliter, and limited availability of rituximab. So there is a additional thing from the 2022 EULA guideline to 2025 BSR guideline. They talked about more about the sinus disease management, and other thing they mentioned, if the patient has severe renal impairment and patient is on dialysis, they consider not to continue the immunosuppressive drugs due to the risk of infections if their patient is already on dialysis. In treatment of sinus disease, sinus care is very important, and some oral or IV medications do not adequately penetrate the sinuses, so we have to rinse with saline or steroids with antibiotics. It's important to use regularly, and reconstruction surgery if desired by the patients, and have to regular exam with ENT team. So other management considerations as the patients on immunosuppressive drugs, and we have to think of coronary pneumonia prophylaxis, and as he is on high dose of steroids for bone health and mental health and sleep pattern and blood sugar monitoring. These are some landmark trials in ANCA-associated vasculitis. So this is a crowded slide. I will go for about few trials. This rituximab versus cyclophosphamide for ANCA-associated vasculitis. RAPE trial. The rituximab therapy was not inferior to daily cyclophosphamide treatment for induction of remission in severe ANCA-associated vasculitis, and may be superior in relapsing disease, and it's included in the guideline. Regarding plasma exchange and glucocorticoids for ANCA-associated vasculitis, here plasma exchange did not, the Pexivas did not demonstrate a significant benefit of plasma exchange, plasma apheresis in delaying death or end-stage renal disease in overall patients cohort. The glucocorticoids, they reduced the dose oral glucocorticoids regime was found to be non-inferior to standard regimen for the composite outcomes of death or end-stage renal disease. Regarding plasma exchange in guidelines, consider plasma exchange for patients with serum creatinine more than 3.4 milligram per deciliter, patients requiring dialysis or with rapidly increasing serum creatinine, and patients with diffuse alveolar hemorrhage who are hypoxemic. The PLEX, the routine use of diffuse alveolar hemorrhage is now not appreciated. The recommendation of plaques in ANCA vasculitis with severe kidney disease, 7 treatments over a maximum of 14 days and 60 ml per kg volume replacement with albumin substitution is recommended. Vasculitis with diffuse pulmonary hemorrhage, daily until bleeding stops. Replace albumin with fresh FFB. Vasculitis in association with anti-GBM antibodies, daily for 14 days or until GBM antibodies are undetectable. The main Registrar trial, the primary trial, the original study compared rituximab to azathioprine to determine which has more effective at preventing the relapses. The primary result, the rituximab was significantly superior to azathioprine. So subsequent main Registrar trials, following the success of the first trial, they conducted 2 more trials. In final conclusions, in the pooled and long-term analysis of the 277 patients enrolled in the 3 main Registrar trials shows that the 84-month sustained remission rate in patients with ANCA-associated vasculitis is higher with the 18-month fixed rituximab regime compared with the azathioprine and to the 18-month tailored rituximab regime. So, extending rituximab to 36 months does not appear to reduce the long-term relapse rates compared with 18 months. 18 months of fixed dose rituximab. There's another trial, Registrar. It's also compared the rituximab and azathioprine in the maintenance regime, but here the rituximab dose is different, 1000 milligram on 4, 8, 12 and 16 and 20 months. Superiority of rituximab was significantly better than azathioprine at preventing relapse with lower hazard ratio. Conclusion, the trial established repeat dose rituximab as an effective and safe maintenance therapy for relapsing ANCA-associated vasculitis, offering a more potent option than azathioprine for preventing future relapse. This is advocate trial. Compared the prednisolone and advocapan. So, among patients with baseline EGFR 20 ml per minute, in the advocate trial, EGFR improved more in the avacopan group versus the prednisolone group. Disease monitoring. Regular, it's a multidisciplinary team management is recommended. We have to collaborate with nephrology, pulmonary, ENT and neurology and infectious disease teams and do the investigations every 1 to 3 months depending on the severity and monitor for the infections and vaccinations, and those who are on rituximab for a long time monitor for hypogammaglobulinemia. And we can monitor the disease activity with Birmingham vasculitis activity score. There are factors that increase the relapse risk. The diagnosis of granulomatosis with polyangiitis itself and PR3 ANCA group and the presence of high serum creatinine and more extensive diseases, ear, nose and throat diseases and history of relapse, ANCA positive at the end of induction and rise in ANCA, and the treatment factors, lower cyclophosphamide exposure, immunosuppressive withdrawal and glucocorticoid withdrawal. There are some recent advances in the treatment. They focused on targeted therapies that reduce the need for high-dose corticosteroids and provide options for refractory or relapsing diseases. Complement targeting therapies B cell depleting therapies, and B cell inhibiting therapies, T cell targeting agents, and targeting ANGA-induced inflammations, and some targeting other pro-inflammatory pathways, fibrosis, and cardiovascular disease. Morbidity, it's depend on disease per se, presence of advanced renal impairment, increased age, and treatment as well. These are my references. Thank you for your presence and patience. Thank you.
Thank you, Dr. Janahan, for that detailed description of. Yeah, it's time for questions now.
Congratulations for the very interesting presentation.
Thank you, madam.
Yeah. So, what is the dose of rituximab they are recommending? Low dose or high dose? Are there any studies supporting that?
Yes, madam. There's 2 trials. First we use the rituximab first dose 1 gram 2 weeks apart. So then every 6 monthly 500 milligram for according to one trial. 500 milligram 6 monthly. So other trial it's recommend every 4 monthly. But the duration of the is the guideline they have mentioned you can continue for 24 to 48 months. But according to the trials they have suggested maximum 18 months, madam. But if it's severe disease we can go for up to 36 months.
Okay, thank you.
Thank you.
I take this opportunity to thank both speakers today for their elaborated talks on these important topics, and thank you all for participation, and I invite you to join us next time on February the 6th. Thank you.